incidence is increasing. The annual incidence of oral cancer worldwide is 2,63,000 and every year 1,27,000 people die because of oral cancer. It's more common in Southeast Asia, particularly in India, and India, Pakistan, Sri Lanka and Bangladesh have the highest incidence of oral cancer, that is up to 25% compared to 6% in France and 3% in UK. Males are more often affected, older generation are more often affected, but a rising incidence has been noted in patients under 45 years of age. And this is the most unfortunate part. 60% of patients present with stage 3 and stage 4 disease. And why it is unfortunate? After all the treatment or possibilities we have, we get only 45 to 32% of 5 years survival rate respectively. Now, World Health Organization suggests that the cancer case will be 15 million worldwide in the years to come, and early detection and prevention play obviously an important role. Now we all know oral cavity is a very easily accessible area, although the tumors of the site cause symptoms at relatively early stage. A large majority of the patient continue to present with late stage disease. And despite readily and widely available treatment, oral cancer carries overall disease-specific mortality 49%, which is very high. Now this is the real situation. Stage 1, stage 2, we get better 5-year survival rate. But when it comes to stage 3, stage 4, we get 30 to 45% survival rate in oral cavity cancers. Even in lip CA also we get round about 39 to 60% survival rate in stage 3, stage 4 disease. Now see, from our graduation level, we are seeing presentation where huge stage 3, stage 4 disease are being excised and fantastic flaps are being used to reconstruction of these areas. But when it comes to patient's benefit, this is the real fact. This is the real fact. These data are from the renowned head and neck units from all over the world, and they have all the equipment, all the surgical expertise, but still they are coming up with these type of data. In 2007, the World Health Assembly passed a resolution on oral health, urging all members of the states to take steps to ensure that prevention of oral cancer is an integral part of National Cancer Control Program, and to involve oral health professionals, that is dental surgeons, or primary health care, that is general physicians, personnels with relevant training of oral health in detection, early diagnosis and treatment. Now general dentists examine their patients' oral cavity during almost every consultation and are in a unique position to both promote primary preventive measures to high-risk groups. We have to classify the high-risk group first and aid in early diagnosis and referral of suspicious oral lesions. And this is very true that unlike other diseases, cancer doesn't involve a spontaneous outbreak, but it is an increasing accumulation of slight pathological changes for 3 to 20 years. There are certain major risks like smoking, alcohol, banana chewing, UV lights, reverse smoking. This all we know. Some micro risks like HPV, immune deficiency, micronutrient deficiency, syphilis, chronic candidiasis, prior radiation exposure, periodontal hygiene, oral hygiene. I think that's because of microbiological load in the oral cavity in case of poor oral hygiene. An increase in the incidence of oral cancer widely predicted and is already visible. This increase is directly attributed to commercially manufactured products like betel nut and tobacco. Compared to the risk, this is very eye-opener data. You must see it. compare with the risk of non-smoking and non-drinkers, the relative risk developing mouth and throat cancers are 7 times greater for those who use tobacco. And for alcohol users, it's not a great news because it's 6 times greater for those who use alcohol and 38 times greater for those who use both tobacco and alcohol. So you can imagine the gravity of the situation. So you can see that oral cancer are broadly is a lifestyle disease. The risk of developing is relatively lifetime exposure, like 20 pack years seems to be the threshold at which a significantly increased risk of cancer is imparted. And you think you have left the smoking or alcohol and you are in a baseline of risk? No. The risk reduces back to the baseline 10 years after cessation. So if you want to stop it today. A number of genetic conditions carries an increased predisposition like Fanconi's anemia, dyskeratosis congenita, xeroderma pigmentosa, Pomovinsel syndrome, scleroderma and diabetes. Now there are certain problems in case of oral cancer screening. Oral cancer screening team includes a clinician, research scientist, epidemiologist, NGO, and in my opinion the most important one is common man. And cancer screening means different thing to different group. That's the problem. Which group of the health professionals should be undertaking the oral cancer screening? Dental surgeons are the one. What do you think? There is an interesting study by Macpherson et al. He surveyed 357 general medical practitioners and 331 general dental practitioners, and he find out that 58% dental surgeons are confident in diagnosis opportunistic oral cancers, rather in compared to general physician who said that only in symptomatic case they can diagnose it. And his survey suggests 37% dentists felt confident in their ability to diagnose these lesions compared to only 15% of general physician. So these data are very clear that dental surgeons are the one who should do oral screening and diagnose oral cancer. Now where lies the barrier to improve performance? Specific education. There is a big barrier. High risk population are infrequent attenders to general practitioners. Why? Heavy smokers and drinkers from low socioeconomic background tend to only present dental care in context of dental abscess and heavy caries, severely caries. And older patients who have a higher risk of cancer are frequently edentulous. So we are missing out in these aspects. Obviously the cost of dental care is high. That's the reason. And cancer suitable for screening should have substantial morbidity and mortality, which oral cancer has. High prevalence of detectable clinical says any day we can detect anything within the oral cavity, and dental surgeons are the one who can do it. Possibilities of effective improved treatment because of early detection. I have shown you that stage 1 and stage 2 disease has got better prognosis, and the problem is that availability of root screening test with high sensitivity, high specificity, low cost, with little convenience and discomfort. Now cancer screening should detect the cancer in earlier than would occurred otherwise, and there should be evidence of earlier diagnosis results, improved cure, and the aim is to detect the cancer at an early stage when it is treatable and curable. However, the reality is different. Now we have some established cancer screening program for other cancers like colorectal cancer screening, which have beneficial effect in reducing the mortality 30 to 80%. Breast cancer screening reduce the mortality up to 25 to 30%. Cervical cancer screening, skin cancer screening, prostate, lung. We have established cancer screening program for other cancers. But in oral cancer, there is no significant direction yet. Now, how morbid oral cancer is, that's why I put this data. This study has been done in England, Scotland and Wales, where registration of new oral cancers in 2006 was 5,325 and death rates in 2007 was 1,851. So the registration and death and registration ratio is 0.35, which is more than other cancers like skin, cervix, breast, prostate, other common cancers. So you can imagine it is more morbid and mortal, the oral cancer. Why it is? This may be the reason. Condemned mucosa and field cancerization theory. The mucosa of the oral cavity should be regarded as a field of growth that is constantly being bathed by carcinogens and therefore will potentially have numerous areas of pre-malignant or early malignant changes. When carcinogenic stimuli affect the epithelial tissue, all the epithelial is affected similarly but not necessarily equally. There is a tendency of multicentric cancer in the oral cavity. 10% cancer of oral cavity has got this tendency. Screening tools what are available is toluidine chloride, exfoliative cytology, oral CDEX biopsy, Visilite. For brush biopsy, the method is brush the brush against the lesion for 10 times, transfer the cellular material to the slide, immediately fix it, allow it to dry and send it to the pathologist. This is how it's working, complete transepithelial tissue sampling, and this is what it looks like, and you will get results like this: negative, positive and atypical. See, this is not the replacement of incisional biopsy. This is the guide of incisional biopsy. If it comes positive and atypical, you have to send the patient for incisional biopsy. Coming to the Visilite, the kit comes like that with chemiluminescent device, 30 ml of acetic acid and light stick holder and retractor. The steps are: patient rinse with 1% of acetic acid for 1 minute, activate the device by bending the outer capsule, shake the capsule, mix the content, insert the capsule into retractor unit, dim room light, visually inspect the oral cavity and obviously discard the material after the use. See, in the light, the normal tissue will absorb all the light and the diseased tissue will reflect it. So diseased part will look like whitish. Coming to the toluidine chloride, it usually stains the DNA, 1% aqueous solution followed by 1% of acetic acid to decolorize the lesion, and abnormal tissue will retain that blue dye. Coming to the oral cavity examination, I think this is the best for screening. You need very simple equipments like good lighting, tongue depressor, dental mirror and pair of gloves. To assess the oral cavity, you may divide the oral cavity in some subsites like both lips and vermineal, buccal mucosa, gingiva, retromolar tract and hard palate, floor, mouth. Tongue, you can divide it into dorsum, ventral surface, lateral surface, soft palate and tonsil. Now, this is the most important part: palpation. Palpation has got a very big role. It's particularly relevant with bulky and firm lesion being of much higher concern than a soft lesion with identical texture to the adjacent tissues. Coming to the pre-cancerous lesion or pre-malignant lesions, now we are using the term potentially malignant disorders. Broadly speaking, these are erythroplakia, OSMF, leukoplakia and lichen planus. I will go through very short. This is the typical look of erythroplakia, and the chance of malignant transformation is 10.3% with high grade dysplasia, and carcinoma in situ is 24.1%. Oral submucous fibrosis, this is the look. You will find whitish oral mucosa and fibrous band beneath the oral mucosa. You will find trismus. The malignant transformation rate is 0.5% per year. Coming to the leukoplakia, this is how it will look. At the palatal region, leukoplakic lesion, the buccal region, in the left buccal mucosa, and the malignant transformation rate is below 1% though per year. Coming to the lichen planus, this is a typical look of lichen planus. Now coming to the clinical presentation of oral cancer, There you will find non-healing ulcers, feeling of irritation or pain, ill-fitting dentures, halitosis, and obviously most importantly palpable marks in oral cavity. You will find trismus and ankyloglossia. These are the findings of stage 4, stage 4B lesions. Refer to pain to the ear, dysarthria, dysphagia, and obviously neck node. Now, broadly speaking, squamous cell carcinoma covers 90% of all oral cavity tumors. Adenocarcinoma and minor salivary gland covers 5% of all oral cavity tumors. Verrucous carcinoma, lymphoma covers 2%, and remainder being uncommon sarcoma and odontogenic tumors. Now, this is the most important part, clinical presentation. This is a typical look of a squamous cell carcinoma involving buccal mucosa, commissural area, upper lip. You will find the indurated border, the granular surface, reddish looking surface, and ulceration over the lip. And this is a soft tissue area, mainly over the lip area, tongue, floor, mouth. You should palpate it and you will find a rubbery mass filling. This is a typical look of the oral cancer presentation. I have given you the smaller lesions so that you can diagnose, you will be habituated with the look of the smaller lesion and you can diagnose early. This is the most important part. You will find this is the indurated border and surface is granular. It's a lateral border of the tongue. The imaging of the choice is MRI because MRI has got the finest soft tissue resiliency and you can plan your surgery according to MRI. You can see the amount of disease very clearly over the tongue. This is a lesion, again a squamous cell carcinoma in the posterior part in the lateral third of the tongue. And why I have put this? Because it has the patient was referred after 2 misdiagnoses and no one used tongue depressor to depress the tongue and see the lesions. You can see the indurated border and reddish looking lesion. This is the squamous cell carcinoma again a lateral part of the tongue involving squamous cell carcinoma, indurated border, granular surface. If you provoke with a explorer, it will readily bleed. It's going towards the floor of the mouth. Now what is this? This is again a squamous cell carcinoma involving whole of the tongue. And why I put this one in my presentation? Because you can see there is a ankyloglossia. Patient can't protrude his tongue properly. This is an indication of extrinsic muscle involvement of the tongue. Now this is where you hit the spot. You should hit the spot. This size of lesion you should diagnose. This is the squamous cell carcinoma, not very angry looking, but if you can diagnose this one, you can save a life. You can imagine the prognostic value of stage 1 lesion, where 60% of the patient miss this stage. Again a stage 1 lesion, a very small lesion. You just have to palpate it. You will find indurated border and whitish looking, not very angry looking lesion, but this is a squamous cell carcinoma in the lateral surface of the tongue. This is again a squamous cell carcinoma, but it has got a different look. That's why I put in my presentation. It's involving in the edentulous area of the alveolar mucosa. Again, squamous cell carcinoma in the buccal mucosa involving the vestibular area also. It's very easy to miss that lesion if you can't retract the buccal mucosa properly. Squamous cell carcinoma involving the palate. The CT scan is the radiology of the choice. In the CT scan you can see there is a huge bone loss. Squamous cell carcinoma involving the posterior soft palate, tonsillar area going to the posterior pharyngeal wall, and you can see there is a little bit of trismus. So this indicates the lesion is going to the infratemporal space and it already has become a T4B lesion, stage 4B. Again a retromolar trigon buccal mucosa lesion, different look. That's why I have put this lesion in my presentation. Now there is no ulceration, but this is a stage 4B squamous cell carcinoma. If you just have to palpate it, there is an induration beneath the mucosa, and the trismus, it's a T4B, stage 4B lesion, though there is no ulceration. Coming to again, this is a tonsillar lesion going towards the soft palate and posterior pharyngeal valve, squamous cell carcinoma. Now, this is a very interesting case. This patient was thought to be having a dental abscess. The patient was referred to me for extraction, and there was an induration on my palpation, and this is the look. This is the look of the lesion, and it came out to be positive after biopsy. Also, this is a squamous cell carcinoma in the alveolar mucosa. It's a very early stage. You should hit the spot at that stage. This patient, the complaint was ill-fitting denture and pain during wearing a denture, and there was a lesion, and it came out to be positive, squamous cell carcinoma. Now, this is a typical look of adenocystic carcinoma. Many a times these are being misdiagnosed by dental abscess, but this is an adenocystic carcinoma, and the aspiration will be negative, and you should go for the biopsy. There is no harm in doing biopsy, but after doing biopsy you can save a life. This is again an adenocystic carcinoma. In the OPG you can find this type of bone loss. This is a typical look of basal cell carcinoma in the bridge area. Now, these are two patients coming with the same type of complaint, trismus and a fistula, pus discharging fistula. But when we did the radiograph, this is the real picture. This lady has got an impacted third molar, and he has got submesenteric abscess. But this lady having a huge virulent lesion which came out to be squamous cell carcinoma later on. This is the CT scan. You can differentiate. In this 3D CT model you will find huge bone loss, and in the transverse cut you will find a lesion involving whole infratemporal fossa. This is the maxillary sinus, lateral pterygoid plate involving the whole infratemporal fossa. This is the stage 4B disease. Now, this is a look of mucoepidermoid carcinoma of the submandibular salivary gland. Now, this is a very interesting case. We don't find very easily these cases. This is the neck node presentation, but there was no ulceration in oral cavity, in indirect laryngoscopy, or in the nasopharynx. But after doing PET scan, we find out okay, this is the nasopharyngeal CA, and you will find this type of presentation with nasopharyngeal CA. Posterior neck part is mainly involved. This is a parapharyngeal CA. This is the typical look of parapharyngeal CA. You have to depress the tongue. There will be elevation of the soft tissue. The uvula will be pushed towards the contralateral side. This is a squamous cell carcinoma involving the base tongue, tonsillolingual sulcus, soft palate going towards the uvula. Now, this is very interesting case. This person came to us with a palpable neck node. There was no lesion in the oral cavity, in the larynx, no lesion in the nasopharynx. We went for the FNAC, and it came out to be a malignant melanoma. It came out to be malignant melanoma. We were thinking that this is the melanotic primary. We were thinking of excision of this primary, but according to protocol, we should do a PET scan. But today it's cost around 22 to 25,000. But patient was ready for the PET scan, and this is how the PET scan looked. We find high SUV value, high FDG uptake in the neck node area, but there is a uptake in the molar region also. And we went back to clinical findings, and there was the primary. We all missed it. That was the primary. So we did the neck dissection, radical neck dissection. This is our primary lesion. Fortunately, we were able to achieve free margins, and this is the recipient site. Coming to another case, this person came to us with this swelling, and that was the clinical presentation. We went for the biopsy. It came out to be benign lesion, but I thought that it can't be a benign lesion. Again went for the biopsy, and it came out to be sarcoma. And after doing the IHC, it came out to be rhabdomyosarcoma. This is an embryonic variant of rhabdomyosarcoma. We went back to theater, we excised the lesion, that was our specimen, and this is 1 day post-op, and surgical template was made by Dr. Shaunak Ghosh, and we have given it to the patient. And that was reported in Times of India also. There is a adenocystic carcinoma, there is the CT scan presentation. We planned our incision, open up the lesion. This is our specimen. This is the 1 day post-op, 1 month post-op. Now I have shown you the smaller lesion. I put this OT pictures to show you how can you give a better life by just detecting the oral cancer in an early stage. That was the lesion I've shown you previously. We went for a neck dissection. That was our margin of excision, marginal mandibulectomy done. That was our specimen. We used tongue flap, and this is 2 days after radiotherapy. You can see the post-RT life, post-surgery, post-RT life of the patient, and that is the intraoral site after RT, 2 days after RT. And this is the basal cell carcinoma. We went back to theater, we excised it, we reconstruct this area with forehead flap. This is the 1 day post-op, this is 1.5 months post-op. Pretty acceptable, I think, post-operative phase. Now, potential for cancer screening for oral cavity has not been fully realized. So the question remains how early you can these lesions can be detected. This question will be a big challenge in the years to come. We have advanced technology, that is clonal change, detecting clonal change or genetic alteration, P53 mutation, mitochondrial DNA mutation, PCR based assay for telomerase activity. The identification of new gene and other molecular marker will help in the early detection in head and neck CA. What is the future trends? Molecular in the urine as early indicators that cancer relevant DNA damage is occurring somewhere in the body. Future trends, biosensors that could measure the tissue specific changes in the saliva to detect early stage of carcinogens. We don't want to see this type of palliative cases where we can't do anything. No, as a surgeon, as a human being, we don't want to see many of these cases. What is teamwork? Nowadays, you find out any literature on oral cancer, you will find out that oral cancer treatment needs teamwork. It has got several aspects like excision of the lesion, reconstruction of the lesion, palliative care, chemoradiation, and all those things. But in my opinion, we missed one thing. Another part of the biggest parts of the most important part of the oral cancer treatment is early detection. And it's a teamwork. We need a bigger team, and this team includes all of you. Thank you.
Thank you, Swagato. Really very informative and excellent presentation by him. I really like to congratulate Swagato for the kind of work he's doing as compared to his age, and is really commendable. Now, may I, any questions from the audience? No? Okay. So, may I ask our chairman for the session? Yes, ma'am, please.
No, if you are suspecting something in vicinity of the tooth, you just do first biopsy, then extract, not beforehand, because after extraction the clock becomes ticking. After extraction, it will spread more virulently through the extraction socket. So you should keep that thing in your pocket later on. Huh? Huh. Nasopharyngeal CA.
Pharyngeal
Okay.
carcinoma.
Yeah.
I have got a
Yeah, tell me. Oh, I think this
Actually,
one.
what was the problem of that
This one.
girl?
Ah.
What was the problem of that girl? What problem she had come?
With the lump in the neck.
Only
That
lump.
that was the problem.
I have got a patient for the last 1 month or more than that. She has been taking antibiotic from several doctors, even medicine doctors. She has got the same sort of lump, no redness, no fever.
You should straight away go for FNAC.
FNAC shows that was a pus, having pus. So, but the antibiotic and all this, she has been taking antibiotic for the last 1 month, but no result, no swelling was gradually becoming formed.
See, then you have to go for biopsy for the lump. It could be lymphoproliferative disease or tuberculosis or something like that.
Yeah, so that was done, no tubercular.
Then you should go for the biopsy has been done.
Biopsy, not biopsy, but FNAC.
See, after biopsy, the test of with MPCR is the confirmatory test for tuberculosis. So, with the biopsy, you have to put the specimen in normal saline, not in formalin, and send for the MPCR. If it comes negative, then you can rule out tuberculosis, not before that. Or it could be a lymphoproliferative disease also. Thank you.
But there was just one thing I wanted to say, which is that, like, even if Thank you. There's just one thing which I wanted to
Yeah,
say, that
please
even if
tell.
an FNAC is negative, because FNAC is not a not
Confirmatory.
a test, so that doesn't really rule out that there's no malignancy over there.
Yeah.
So if clinically we feel that there are markers or there are indications as to there could be malignancy, I feel biopsy, incisional biopsy, excisional where possible, definitely is a more straighter approach, and we reduce time also. I feel.
Yeah. That's the main thing.
Yeah.
You should do biopsy before that.
And also for CA patients, one thing which since you are doing, like Dr. Ghosh said, at a very young age, very commendable surgery. One thing also I feel is very important, which we need to look into, is also the quality of life post surgery.
Yeah.
So just ablation doesn't really. I mean, it is you are getting the patient disease free, but if you can give the quality of life back by the reconstruction, that actually helps a lot.
Obviously, reconstruction plays a big role, but I was more
Well, I'm
into.
just generally, it's a suggestion. I'm not,
Yeah, definitely.
Because I've seen reconstruction because of financial situations and things
No,
with
no.
the patient. No, it can.
If it requires, you should do reconstruction, definitely.
And like you said, plastic surgeons, also microvascular surgeons, play a very important role.
I play a very important. It's a team effort.
Thanks.
Thank you.
Okay, so now may I ask the chairperson, Dr. Avantika Mukherjee, to present the token of appreciation to Dr. Swagato Chowdhury. Dr. J.K. Singh, may I please request you to present the certificate of attendance to Dr. Avantika Mukherjee.